So it's my pleasure to kick this off by introducing Art Glasgow. Art is the Chief Technology Officer from Ingenix. He has a very distinguished career in healthcare. At Ingenix, he has previously led their health information networks business and also been involved with their payer and government businesses. He has a very thorough knowledge of all of those, as you will understand if you engage in dialogue with him. Prior to Ingenix, Art worked for Misys Healthcare, now Allscripts, and Inflow Inc., now SunGuard. So he also has a great deal of experience in managing very large data centers and providing products and services to hospitals and physicians alike. Art is an ex-Marine, so don't mess with him.
Former Marine, ex-Marine.
Oh, okay, a former Marine, I apologize. So, but I would encourage you, nevertheless, to ask Art the hard questions. Art's going to talk a little bit about the Ingenix vision and how Ingenix is organized and what Axolotl means to Ingenix.
So, Ray, thank you, first of all, for that introduction. Well, I don't have Ray's catchy accent and won't try to replicate that. Ray did mention my Marine background, and one of the things that we used to say in the Marine Corps is shoot, move, or communicate. Right? There's only 3 things that a Marine lives to do. And I think that's important, and it's something that has guided me throughout my career as I look at especially this deal and the marriage between Ingenix and Axolotl. You know, Axolotl has a very specific purpose, and I view that as kind of the shoot. Communicating means, you know, if you're not in a position to take the shot, you should be communicating with someone else who can. And I think that's where Ingenix starts to come into play, right? We have a lot of different shots that we can take at Ingenix that weren't open to Axolotl, but now they are. And you know, when we're really talking about moving, moving's about speed, it's about velocity, and it's about change. And we're in a point in the industry right now that speed matters, right? There's going to be a lot of change that's coming, and the vendors that you choose to work with, the partners that you choose to stay with, are going to have to move faster than the market, otherwise you're going to lose. So today I just want to take a few minutes and talk about a couple of different things. I want to introduce you to Ingenix, first of all, who Ingenix is. It's a name that you may have heard, you may not have heard. I would bet there's probably no one in here that knows the full breadth of what Ingenix does. I didn't before I joined Ingenix as well. I also want to talk a little bit about the strategy behind the deal, how we view the market, why we did this deal in particular, and what we view the HIE space as today and where we think it's headed. And then finally, I just want to talk a little bit about where we're headed together, some of the roadmap that we see in front of us, some of the change that we see coming, and save some time for your questions. And you know, please don't limit yourself, as Ray said. Ask me whatever questions that you feel you'd like to. So this, I haven't really looked at all the slides yet, so this should be interesting. All right, so we are an industry leader in healthcare information technology. Ingenix isn't a company that's been around for 40 or 50 years. It's really a compilation of companies, some of whom have been around for that long. But we were formed in the late 90s really to tackle a few problems about improving the healthcare system. We are part of a larger organization, which is United Health Group. United Health Group is really split into 2 different sides, right? So there's a benefit side to United Health Group. Some of the brand names, the 3 primary brand names that you may recognize are United Healthcare, Ovations, which is managed Medicare, and AmeriChoice, which is managed Medicaid. Some of the brand names that you may not recognize over on that side of the business are Evercare, which is post-acute care, hospice, and home care. Golden Rule, which is individual insurance. AARP, which is also United Healthcare benefits behind that. And then TRICARE for half the country is also run by United Health Group. On the health services side of the business, which are 3 independent, separately operating companies, separate management teams, in some cases separate boards, there's 3 primary brand names. There's Ingenix, which is a health informatics and IT company. We have Prescription Solutions, which is a top 3 PBM in the country as well. And we have Optum Health, which is a behavioral and informatics company, as well as a case management and a care management company. So these 2 companies, or 2 operating halves of the overall whole, really exist for one purpose, and that's to improve the healthcare system to help people live healthier lives. And they bring with it a massive resources, $90 billion plus in revenue, that are applied in ways that I think will surprise you when you learn a little bit about it. We are a pretty large company in our own right. We're about $2.5 billion from Ingenix point of view, about 12 to 13,000 people, 1,500 of which are clinicians. And outside of the clinicians, we also have scientific expertise in epidemiologists, biostatisticians, analytical statisticians who help us create many of the informatics that we use to apply against pressing problems. Who we really serve at Ingenix, we like to think of it in three basic buckets. There's those that diagnose and treat, so it's primarily providers who are out there in the community, whether those are facility-based or ambulatory-based providers. We have a suite of solutions that we apply towards the problems they face every day. Those who pay for care, which are primarily insurers today. So we do service other competitors of United Health Group. It's often a fun topic to discuss with our corporate brethren, but we think it's important to serve the system, not just specific participants in the system. And those who supply the cures. So Ingenix is the one business within United Health Group that has a very strong life sciences focus as well. Our subsidiary I3 is involved in CRO business, post-trial business, pharmacovigilance, and that's our largest international business as well. So we are in over 126 countries today. I think before we talk about why we did the deal, though, it's important for me personally as an executive at Ingenix to give you an idea of how we do business and what's important to us. And I think these are the touchstones that will help you gauge whether we're successful or not as we work together. So our company is very separate in terms of operating principles, right? The health services business is very different than the benefits business. And even within the services business, we have 3 separate operating companies. But what ties us together, or ostensibly what should tie us together, is a common set of values, right, that should work together. So integrity, compassion, relationships, innovation, and performance are more than just words to us. And while we may not meet the mark in every single one of those categories all the time, this is what we're striving to do. And I want to talk just briefly about a few examples that should hopefully make you feel a little bit more comfortable about the fact that these values mean something to us. So we launched a campaign about 1.5 years ago that's outlined on the bottom there called It's Personal. And this is primarily around the value of integrity and the value of relationships. Our provider business is about $1 billion strong when you combine all of the different solutions that we run. And one of the things that we understood very quickly was that privacy and security and the integrity of that data are very critical, especially for a vendor who also serves payers, and not just our own payer that we're partners with, but Aetna, Humana, Cigna, every single one of the Blues plans, and many of the regional players out there as well. So we launched a campaign that wasn't just about IT, wasn't just about actual technology, but it was about culture. And we've made a big culture change throughout Ingenix over the course of the last 1.5 years since we launched this campaign, in trying to make this personal for every single claims processor, every single support desk personnel, every single one of our 12,500 employees, to treat the data that they touch as if it were their own data. There are significant consequences associated with this, but more importantly, significant training. And this is something that we never intended to be talked about externally, but over the course of the last 18 months has picked up so much momentum that we're actually doing this for some of our customers now, putting in a privacy and security framework for them through our Ingenix consulting arm, which is a 1,500-person strong consulting and implementation arm. I also want to talk a little bit about innovation, because this is why, at the heart of it, why we did the deal. And why you should be excited that we did the deal as well. The Wall Street Journal today, there's a press release that will go out, but 2 days ago they published their annual awards for innovation. And in the health IT sector, the #1 winner was HHS Connect, which is great. You know, we all have our opinions as to how Connect works and how Connect doesn't. But the thing they keyed upon was Connect was able to get adoption, real physician adoption and real agency adoption in a very short period of time. So hold that in the back of your head. The first runner-up was Ingenix, for Ingenix Health Impact, for our ability to use analytics to create a product that does disease marker precursor identification, that we can actually predict, based on the data that's available, what diseases a person might be able to get based on solid science and solid evidence, to actually save lives, and to push that towards the actual desktop, so it's not just rules-based clinical decision support, it's person-based clinical decision support. Now, those two things, and the Wall Street Journal doesn't understand our strategy, and we haven't talked to them about it, but you put those two things together, that's kind of our strategy. That's why we did the deal, to take intelligence and connect it to the physician desktop so that it's meaningful, so that it's actionable, so it saves lives, so it reduces costs, so it improves the system. And this type of innovation is the type of innovation that Ingenix has been known for since our inception. We don't often think of ourselves as the largest company in HIT, although I think we are, and I think we're going to continue to be and grow. We don't often like to think of ourselves as perhaps the most efficient operating company, although we are, and part of our culture is very strong performance-based in operations as well. We look at ourselves as innovators. We look at ourselves as tackling problems that are either too hard, too difficult, too complex, or may not have a market for today. We started this product, Health Impact, over 2 years ago, with no real market for it. Nobody really asked us to come and deliver a predictive disease modeling solution. But we saw a need for it, and we thought that this would be something that could change the game. And we're now at the point where we're starting to push it to market. So we're using it with DoD, for instance, to do post-traumatic stress disorder identification in pre-enlistment candidates. And it's proven to be very, very effective in terms of its hit rate. We're aiming it at disease states like hypertension, diabetes, the highest cost centers for many of the organizations that are part of your HIEs today. And this is something that we think through Axolotl we can begin to deliver closer to the desktop and actually move the curve. So why we did the deal, right? Other than the Wall Street Journal seems to think we should have done the deal. We see a big shift in the market that's coming, and HIE is only a very small piece of it. And there's a lot of stuff on that slide that I won't necessarily go into detail on. But the general point of it is today, all the constituents in the healthcare community are at odds with one another. It is a fee-for-service system that is predicated on volume. It's broken, and we believe that it is going to continue to be broken, and it can't be fixed. From a UHG point of view, when I put my hat on as an executive at UHG, I can tell you that my colleagues who are on the benefit side of the business are scared to death. They see insurance reform as the final wake-up call to have to change their business. The 85% medical loss ratio requirement that is placed upon them means that no longer shifting cost can't be an option. It's not a strategy. There's no more pie left to be able to get cost out of the system. The last long pole in the tent is actually reducing the cost of medical care. And to do that, we think there's really only one model out there that's proven to work, and that's the ACO model. And we can argue about what ACO means, whether it's just a bundled payment type of model, whether it's an actual collaborative care type of model. And I think CMS is still arguing, right, about what it means, as the rules haven't been fully identified. But I think one of the things it does mean is a collaborative environment that is powered by a couple of competencies, IT and connectivity being one of them. We have to share data. We have to share systems. We have to share risk. Sharing risk is the most important one because that's going to keep everyone honest. So today, for instance, in Phoenix and in Las Vegas, and I'll talk a little bit about this later, United Health Group is funding the creation of ACOs on their own, with their own dime, to try to prove that it can be done and try to prove that we can actually lower the cost of care. And one thing you may not know about United Healthcare and why would they do this, right? Because they have the best reputation in the industry for being friendly, right, to communities and providers. That's a joke. She got it. United Healthcare is actually at risk. You may not know, but United Healthcare owns delivery systems. United Healthcare owns IDNs. Southwest Medical Associates in Phoenix is owned by Sierra Health Plan, which is owned by United Healthcare. United Health Group owns, through the Evercare subdivision, owns over 200 hospice and home care agencies, post-acute. So actual ownership of these agencies has, as you would expect, motivated them to figure out how to lower the cost. And this is the model by which we did it. Now, Axolotl is a key component of that solution set, and Ray and team are actively engaged in Phoenix and with Las Vegas right now to figure out how we bring all those solutions to bear through a connectivity fabric that is very flexible, very fast, very real time, and can allow us to push that information to the point of care. Oh, I don't know what's on this slide. This is good. Okay, so today we look at the HIT world in really these three different buckets, disconnected buckets. There's tools that are out there that operate in one of these different venues. And the argument today is really usually around one of these specific venues or the other. So up in the upper left is where most of you probably live most of your days, working with your providers to drive adoption. And we can all talk about the programs that are associated with that. In the upper right is kind of business as usual that occurs outside of the HIE space. So a big map of connectivity where your providers are already connected to payers and to each other to do the daily business of what it takes to get work done. And down in the bottom are the weird companies, right? The ones that are out there doing disease management, working with employers or having case management that we got to figure out. We know it connects somehow, but we don't quite know how. Why we did the deal? is because we need to bring all those together with the patient in the center. We operate in those three circles today. Ingenix has a long legacy of providing solutions for all the venues in healthcare, but what we have not done a good job of is connecting them into a more holistic fabric that can then be delivered closer to the physician desktop. We run case management and wellness programs today for all the major employers in the country. We eat our own cooking. I have to go twice a year and get my BMI taken and my cholesterol taken, and if I do all the steps associated with the United Health Group, gives me back $400 on my premiums for healthcare. We don't see any reason why that can't be done through connectivity, through HIEs. In fact, we're doing it today in certain areas. This is some of the stuff as to why we did the idea and the deal. From an Ingenix point of view, our strategy is really three things. It's about taking healthcare intelligence, where we are the unquestioned leader, where we have analytics that power just about every major database that's out there, where we run 28 state Medicaid databases today, and we're a prime contractor to CMS for many of their comparative effectiveness work. And probably many of your organizations and hospitals have some of our analytics installed today. But connecting that through a connectivity layer where we're not the leader today, where we think Axolotl is, to really get into the healthcare workflows, to be able to deliver this data, not as data, but as knowledge, as intelligence, which means in the context of time and the context of setting. But there's changes that need to occur to do that, and this is the journey that we're on together, Axolotl and Ingenix. Again, a lot of stuff on here that I won't go through, but some of these themes probably resonate with you, right? We need to move to a real-time world. Informatics or analytics need to stop being about data, but being about behavior. How do we use the data to actually change behavior? Because in the end, it's actual patient behavior that's going to lower the cost of care. Privacy and security can't be a thing that you guys pull your hair out every time you go to talk about it, right? It's got to go from being defensive to offensive, and technology can be a big part of that as well. And we need to get away from trying to automate the processes in healthcare that don't work today, but using knowledge to drive the actual process. So re-engineering process through better information and intelligence. But one of the things that we are committed to is staying connected to the provider community, to the clinical community as we do this. So I mentioned we have 1,500 clinicians that work in Ingenix. That's not enough, right? Because they help us sell, they help us build, they help us with an idea of where we should head. But what they can't do is help us is what's happening in Danbury, right? Or what's happening in Indiana, or what's happening in Ohio. That's where we need partnership. And going back to our core value of relationship, that's one of the things that we're committed to not changing, your relationship with Axolotl. We hope to add to it. We hope to get more exposure to what you're doing in your communities so that we can bring our capabilities, not necessarily our products, to bear in helping you solve some of the problems that you face every day. Again, a very, very busy slide that's up there, and I want to leave it up just for a minute because it gives a breadth of what we do in the provider space, and this is by no means the extent of it. But when you look at Axolotl right now, look at them as being backed by a very large partner who brings a lot of different capabilities to bear and intends to do so over the connectivity framework that you've already invested in. We don't believe that this is a situation where we are going to be able to push a lot of these tools in the future in a product basis. I think that day has ended. Where the market's headed now is really about using what's available as solutions to try to get at problems. And that's a wonderful opportunity for Ingenix because we've got lots of stuff that we solve problems in a silo today, and we understood the need to partner with someone like an Axolotl so that we can begin to deliver those solutions and that intelligence closer to the workflow, closer to the desktop where you live every day. So what's the future look like, and what should you guys come to expect? Well, here's a really busy slide that clears it up for you. This is actually an internal slide that we used to help sell the rationale for why we did this deal, why we came and talked to Ray and to Glenn and to Lalo and to the rest of the team, because we see the need to change the way the system works. It's not just changing some pieces of the system, it's the underlying system itself. We think HIE is in danger of making the problem worse for itself. You know, the connectivity map today in healthcare is already busy. It's already disconnected. Every one of your providers already connects to a clearinghouse. They may have a separate solution for referrals. They may use fax. They may use all these different things, and you're asking them to hook up to yet another connectivity solution to handle clinical data. That's got to change, right? So we believe that the middle needs to change to support the ends better. Clinical and administrative data and financial data will begin to merge and begin to come together. Intelligence won't be a product that we hook up or a database that you have to implement. It'll be resident in the cloud. It'll be something that's just available to the system. And transactions will feed that data every day so that you get smarter the more that you do, and it'll incent adoption. Now, that's a real pleasant vision, and it's a long time to get there. I get it. Remember, I came from MISIS, so I know what it takes to hook up a EMR and a practice management system door to door. But you have to start somewhere, right? And if you don't have a point in the future to aim at, you end up getting to where we've gotten to today. The good news is when we put that slide up at our first meeting with Ray, he jumped up, and as Ray can only do, said, you guys get it, right? That's where they were headed to, but they didn't have the means to get there. We have the means, right? They already have the head start. They have the widest footprint in the industry. We have the best analytics, the best intelligence in the industry. It makes sense for us to start putting this stuff together. So here's just some of the use cases, short-term and long-term, that we're aimed at. And this is by no means a roadmap, so please don't write it down and ask Anand when he's going to deliver it. Because it definitely is going to require some partnership outside of just Anand. But these are the types of things we're thinking of. So short-term, you can look at the things that Axolotl already does today, perhaps enriched by a wider adoption base that we can bring, as well as some of the things that maybe Axolotl doesn't do today that are pretty simple, that are database level that we can begin to integrate. For instance, a health plan is usually really good at keeping provider registries, credentialing databases. They have to manage a network, right? Wouldn't it be kind of good to have some of that information available to a community so that you could actually know all your providers within your community without having to match them necessarily? So you could understand what providers are credentialed where from a single source of truth, so that you could leverage the data that many HIEs are asking for plans to distribute today, just native in the system. You don't actually have to go build it. You don't actually have to go beg for it. It's already there. That's the type of stuff that we're going to look to do short term. I think Care Tracker is something else that you're going to see us focus on short term. For those of you who haven't met Russ Keene, Russ, please raise your hand. Russ is our general manager who runs our Care Tracker business unit, which is our EHR, which is, as of today, CCHIT 2011 certified. Meaningful Use certified. There you go. Glenn and Russ will be working together along with the team to really bring that alive in a natively integrated fashion with Axolotl, to add to what Axolotl's already done and start to expand the level of value that's available to your communities and to your providers. Now, long term, this is where the exciting stuff really gets to, right? And long term is actually not that long in some of these cases. We believe an HIE needs to be an important step in the food chain, not just another step in the food chain, and it should be the first aggregation point closest to the provider. So things like gap in care messaging, gap in care identification, being able to do population-based total health management, which includes the need to do case management and care management. These are things we do today. We provide them already, either through Ingenix or Optum Health. We simply need to provide them through Axolotl so that they're available to your communities. Drug surveillance. Some of the other acquisitions Ingenix has done this year, if you've been reading the press, I'm like double diamond status now on Delta for having to fly around all these places, but we acquired Pisces, which is a high acuity workflow vendor. We acquired Quality Metrics, which is a patient-reported outcomes company. You can begin to see where some of this is headed, right? We begin to hook all this stuff up together on a fabric that connects to a cloud, and now all of a sudden you can actually close the loop on what happens to that patient from the moment he enters your system through all of his venues of care, that we can track the care pathways and improve the care pathways through intelligence because we'll see both sides of the equation. It requires trust to do that, and I think that's where going back to our core values is important. But this is where we're headed. So some of the stuff that you should expect short term. I think you should see us accelerate the development of the technology on Axolotl. So Anand's talked to you, and I think he'll talk to you a little bit later today about where they're headed from a technology standpoint. The good news, it's very consistent with where Ingenix is headed and where we already are. The even better news is we have a lot more money than they do. And the best news is that we intend to make it move faster, right? Because all of the stuff I showed you on the previous slide doesn't happen unless the Axolotl platform gets to where it needs to be. I think you're going to see us work very collaboratively on a joint solutions roadmap and get better about communicating that roadmap to the market and to you. I mentioned shoot, move, communicate. Well, Axolotl's only had a chance to shoot, right? And they've been very successful in just doing that. We need to prove the ability to communicate as well, and that's some of what Ingenix brings to the table. We are very structured in how we approach the market, how we approach our development plans and our roadmaps. Russ is already working, with the Axolotl team for the first step in that, which is an integration roadmap around Care Tracker. You should expect to see more of that go on as this relationship unfolds. But don't expect too much too soon. We say we like our new best friends, but we don't want to crush them by hugging them too hard, right? So we understand what it's like for a small company to kind of all of a sudden become part of a $2.5 billion company, and we have to be cognizant of that. We are forcing ourselves to be a little bit hands-off so that we don't break the good thing that has been built and has served you here so long. Integration with the analytics suites are working as well. So Andy Lasso, where are you at? Raise your hand. Andy Lasso in the back of the room is the leader at Ingenix who's most responsible for our clinical analytics, and it's no mistake that he's here with us this week as well. Andy is going to be largely charged with working with the Axolotl team to bring some of those clinical analytics to life, and those are analytics both on the provider side as well as on the payer side. So being able to do things like provider measurement in one place so that providers measure themselves, and lo and behold, they actually get the same number that payers do when they measure them, to form the basis for perhaps a more collaborative payment system, right? We're doing it in Phoenix. Bundled payment requires trust. Trust requires transparency. That's going to be some of Andy's job right there to get some of that done. And then I mentioned the EHR synergy and integration as well. But this is where we get to the interactive portion of the discussion. And I know many of you have some questions. Some of you have been kind enough to share them with me in private. I want to encourage you to ask them here publicly, though, because, again, our core value of integrity compels me to do this publicly. Please ask me the tough questions and don't hold back. You're not going to embarrass me, and believe me, I've been on the road with Ray for the last 8 weeks now. They've already been asked in many cases. But anything you want to ask, whether it's about this strategy, whether it's about our actual roadmap, which I may not have detailed answers for you yet, or, I don't know, say, for instance, lawsuits or anything like that, feel free to ask them.
Like we discussed outside, when I was at a medical Department of Medicine business meeting the day after this was publicly announced, a few hands came up, and I had no knowledge of this. The first one was, is this the company that's been sued by a bunch of medical societies, was number one, and number two, are these the guys that are owned by United Healthcare, the most, like you said, provider in our area? And so both of those issues,
yep.
I know you've briefly spoken about them, but are serious concerns, at least in my community,
sure,
in terms of this marriage.
So the answer to the first is yes, we are that company that got sued by the American Medical Association and the New York Attorney General, and I'll be happy to go into some detail on that. The answer to the second question is no, we're not owned by United Healthcare. We're a sister company of United Healthcare, owned by United Health Group, which is a operating company in and of itself. So United Healthcare is just one of the 6 major companies. Would you like me to address the suit in detail, or does everyone feel like they have enough information on it? Okay. So I'm uniquely qualified to address this. A quick story. On my first day at Ingenix, I have the coffee cup, right, but I don't yet know how to get to the bathroom. I sit down at my desk, and I was running a P&L, as Ray mentioned, in the payer and government space. And my phone rings. I sit down at my desk. I'm there 5 minutes, and it's the general counsel for United Health Group, which I thought was odd for your first welcome call, who reads me a disclaimer and says, I need you to respond yes, and now I need to bring you up to speed on some stuff. One of the businesses that you are so lucky to run is being sued by the New York Attorney General, and we're in the midst of a settlement, and you need to be aware of the details. So in a very short order of time, I got very aware of the details and the history behind this. The suit revolves around 2 databases that were really used to set customary and usual rates for out-of-network care provided by insurers. The lesser-known use of it was actually to set market rates by health systems as well. So health systems bought the data so that they could set their price lists in competition with health systems across town. The databases were bought by Ingenix, one 15 years ago, one I think it was like 20 years ago, one from a trade association and one from a small startup company. And they were the PHCS, the Prevailing Healthcare Charge databases, and the MDR database. One database operated under a true algorithm, which basically said we compile all the data by charge for this specific procedure, and here's the high and the low, right, of the charges across geographic regions, and you choose. And the other used a derived data method, which is almost exactly similar to how Medicare sets its charges, right? So lots of information goes in, magic happens here, and then numbers come out, right? So very similar to the Medicare rates. The issue arose when the New York Attorney General charged that Ingenix had a conflict of interest because, as he thought, we were owned by United Healthcare, which we're not. That we were selling this data to United as well and using it in the industry to help set out-of-network charges. It was also disputed the quality of the data and the answers that the data provided. Now, in the course of that suit, what came out of it was that the methodologies were sound. The settlement doesn't address the actual use of that data or the statistically relevant algorithms that drive the derived methodology. The suit was based on a conflict of interest, which we acquiesced to and said, you're right, there may be a conflict of interest here. So we divested the databases to a nonprofit agency that was set up by the New York Attorney General with the AMA's compliance, which is called Fair Health, which, as the story goes, right, is led by Syracuse University. So those very same databases today live, and they're operated as they did way before the suit. The same people buy them. We just don't operate them anymore. And many of our people went over there as well. So that's kind of the story behind that. Now, there's a lot of other suits that are out there. Some of them are follow-on suits from the AMA settlement. So state medical associations have followed on. There are some that I don't know about that are localized that may be around contracting, with UHC. I can tell you Ingenix isn't a party to any of those suits, but we still do care about them since it's part of the overall corporate structure. But that's kind of the long and the short behind the New York Attorney General. If that doesn't resonate with anybody, please feel free to go to the New York Attorney General's website. It is on there. You have to search for it a little bit because he sued a lot of people since us, so those press releases moved to the top.
Yeah, I had a question about the kind of the strategy with CareTracker. I think all of us know one size doesn't fit all in terms of physicians, and the functionality of any particular EMR may not work for multiple specialties, doesn't work in different care settings. Everybody likes different flavors of Kool-Aid. So I guess maybe I missed it, what's the interoperability strategy in a community that may have 17
Sure.
different EMRs and CareTracker may not be present there?
Yeah. First of all, thanks, Todd, for the question. I think you're not going to see any change at all. We believe HIE is always going to be a multi-vendor situation. Well, healthcare really is a multi-vendor situation. So we have no plans to make CareTracker, sorry Russ, CareTracker the only product available on Axolotl. In fact, we work with a number of other EHR providers today, and many of our other businesses. We're one of the largest implementers of Epic. We're one of the largest implementers of Allscripts, and you'll see us continue to do that. Anand and I have had some initial discussions, and he understands where we're headed from a platform basis. I think you'll see us expand the use of APIs to allow for the easy integration of whatever you may have on the ground, assuming that vendor can handle it, right? I think what you'll see us do, though, is seek to integrate our stuff cleaner and better and closer to the desktop, which you'd only expect if we can control the code. Paying customers only, Glenn. Sorry.
So could you explain a little more your relationship to other payers?
Sure.
And what you expect their reaction to be to the deal here?
Sure. So we do service every major payer in the country today. I think we have something, Andy, correct me if I'm wrong here, but we have something in every single Blues plan today. We work with all the state Medicaid, so the governmental payers as well, and we manage the databases for 28 of them. I think those payers that are more regional in focus, those payers that are perhaps not as focused on the IT side of things, have always been extremely good partners of Ingenix. We help them drive value from their data. We help them outsource their business processes. We help them do their jobs better. And I think in the face of insurance reform, they've only moved closer to Ingenix in trying to get some more of that value, right? We operate at a level of efficiency that many of their current vendors don't. I think the payers that do have their own strategies around this stuff, they may have an eyebrow raised, at this point. They're not quite sure where we're headed. I think the industry in general is not quite sure where we're headed. We just bought a lot of stuff, over the course of the last 18 months. We've had a lot of stuff before that, but we've only started speaking publicly very recently. We've usually been pretty quiet. I think they're still going to continue to work with us, and I think region by region, and this is where you guys need to lead us. This is not a payer-side strategy. This is a provider-side strategy and a community-side strategy. They're going to have to engage within the communities that they operate participate in, or they're going to be left out. And we'll continue to sell them products and services on the back end if they so choose, but we're going to make it clear that we expect this to be done in the context of a community. So for instance, a good example, we've had several discussions around multi-payer COB, right? They're all interested in it. They look at it as a better way to save money, which they should save for care that they shouldn't pay for. We don't think the right way to do that is by creating a separate exchange where 9 payers band together. We believe the right way to do that is where the care is delivered. It's locally, right? It's around communities. It's around states. So we look to leverage the investments we've made to create those solutions for those other payers. Did I answer your question?
Yeah, thanks.
Okay.
I have a question about the Accountable Care Organization. Clearly, you see HIE as a central player there. Now, in my community, I hear rumblings that say, well, gee, if we're a health system and we're an accountable care organization, why do we need an HIE?
Right.
So I'd be interested in your take on that, because there's a sense in our state that pretty soon there won't be any more independent providers left.
Right.
So what's the role of HIE in that environment?
So thank you, LaDonna. And I think part of it is the difference in the use of the term HIE, right? So when you guys think of HIE, you live the life every day of a board that argues with each other and different constituents and trying to make the simplest things happen, taking 10 times the amount of effort, because it's people-based HIE, right? When we talk about HIE, it is that too, but it's more about technology underlying the HIE. HIE as a platform, HIE as a cloud. And I would argue if you went to those ACOs and you said, great, you don't need HIE. Do you need something to connect all your physicians? Yes, got it. Do you need clinical messaging? Okay, got that too. Are results in there? Okay, good. What you need is an HIE platform, right? So whether they want to call it that or not, what they really need is a solution that does many of those things today, but is integrated closer with the business processes that are really going to drive an ACO. The follow-on there is one of our largest health systems just decided to go with Epic for their hospital and ambulatory EHR, and so they're thinking, well, we can do all this. Yeah, which is, I suppose, in a single vendor view of the world, it's possible. You just got to bet whether you think we're going to get there or not. I don't think so. Plus, it'd be a lot less interesting, I think. So. Yes, Glenn.
Don't worry, Art. This isn't the tough question. Now, I just wanted to comment on Todd's question. We like to say that we have, in the EMR connectivity world, we have friends and we have best friends. We want to connect to every EMR that's out there deployed in the physician's office. And then we have EMR partners that have stepped up to the plate to do a higher level of connectivity, to do it better, faster, cheaper for the physicians. Some of them are in this room right now. Rich, stop writing, stand up, say hi, from Greenway. So we have EMR partners who have done web services integration to our platform so that this works better for our customers. We definitely are going to continue that. Sorry, Russ.
Yeah, and it's such an important point because there's, as Todd pointed out, there is no one solution that works for all specialties. Ophthalmology, PT, anesthesiology, all these specialties that really have unique needs aren't served well by a single product. Is there a question over here?
Good morning.
Hey, Tom.
In New York State, we have governance, like any other state, if you will, around the use of patient data, different levels of utilization. And Art, as I heard you talk a little bit about the health impact product, the predictive modeling, I think it's possible there'd be some sensitivity from the patient advocacy perspective as to how that tool could be applied at an HIE level and, in effect, provide some level of unfair advantage with regard to rating the patient population, predicting where they're going to be. Can you address? Have you had to deal with that issue or?
Yep. Let me go back to
discuss
this picture there. So, first of all, I think when you look at United Health Group in the context of operating within specific states and within specific HIEs, you have to understand that because of the breadth of our organization, we're going to play a couple of different roles. On the plan side, where they participate in HIEs, they're actually covered under your DRSA, right? Because they're a member of your HIE. Wisconsin's a great example, where the plans are actually members of the HIE, contribute data, have rights to use the data as limited by the DRSA. Ingenix doesn't play that role, right? We're a vendor, so we're covered under HIPAA, we're covered under high tech, and we're covered under contract. So both sides come into play here. I think when we look at specific states, right, if the plan is participating, then you will already have established uses of that data that they'll have to subscribe to in order to become a participant. And as a vendor, then we're going to be prohibited by contract and by law from violating that DRSA, right? So we're no different than Axolotl, we're just bigger, and we're covered under the same laws. Now, some of the things that we need to talk about in terms of where it's appropriate to touch some of that data. This is actually where international experience helps quite a bit. So we're a major contractor for the NHS, and, which is the project going very well in the UK. It's pretty big. And one of the stipulations that the NHS has is that the data cannot leave England. It's not the UK. So we can't even ship it to Northern Ireland or Scotland. It can't leave England. So we had to recreate solutions about how we would provide this level of solution within a specific locale. And that's to say, I think there's places closer to your state or your community where it's appropriate to run analytics. And then there's analytics that are more appropriate to run on a geographic-wide basis, a step closer back to the cloud, maybe. And that's where I think your specific regulatory environment is going to have to guide some of the implementation of that solution. We're flexible enough to do it across both sides. You just make it a better answer the wider slice of pie you look at.
I get it, the elegant solution. I see how all the parts and pieces fit together, but communities and states are totally illogical. And if they're trying to get to sustainability and they have multiple stakeholders that have to bring them there, all you need is one stakeholder who says, I'm scared of Ingenix, I'm scared of the health plan, I'm not letting them in the door.
Yep.
And you locked Axolotl out, even though Axolotl plays that neutral role that brings all the vendors in. I think you're going to lose some big opportunities because people just won't let you in because of the risk.
That's right. So, to carry that over to professional, things do settle down, right? And then logic hopefully begins to sway the day. It's easy to talk about this stuff when it's on a PowerPoint, right? And it's easy to say no to it when it's on a PowerPoint. When we do this in Phoenix on our own dime, and if we can reduce the cost of cardiac care even by 300 basis points, then it becomes really easy for people to start to say yes, right? That maybe that decision we made emotionally, well, they're actually lowering the cost of care. So it's on us to actually get the proof points in the market that show that this can be done. And my bet, both personally and professionally, is that some of these other issues begin to melt away. Because we've gone in and talked to them, and I think, in the majority of the cases, people understand once we explain it to them how this really works, and we're willing to back that up, either by what you already have in your existing contract or talking about, what protections that we can provide. Because the strategy has nothing to do with taking your data. We have too much data already. We know what to do with it, to be honest with you. All right, we got time for maybe one or two more. One more.
Some of what you've communicated here today, it's a little hard to impart that without some tools. And, I do feel the data that you have is super valuable, and this partnership is super important to us. And I'm here representing public health, and we are particularly interested in seeing the new models that look at cost and prevention promoted, and we see Axolotl as one of our vehicles for doing that.
If I could leave you with anything, I would just leave you with, this is exciting, and it should be exciting for you. It's exciting for us. Axolotl was one of the true gems out there in a very small industry that's about to go through a lot of change. And we're very fortunate that we were able to secure this arrangement and this relationship with Axolotl because it's so pivotal to where we're headed. While you may still have some concerns, while your stakeholders have concerns, and hopefully I've done something to quell your concerns today, but that doesn't speak to when you got to go back home to the ranch, as you put it. Please ask the questions. Please come to us and ask for help, and we'll be happy to explain it. I think if you look into it, we're already there today. We're just under the covers, behind the scenes, or in places that you wouldn't expect to see us. And I think you're going to see us show up in places that will only make this investment more valuable and only make it, for lack of a better term, more unavoidable to not work with Ingenix in some respect. The innovation slides that I showed you are just the beginning. 5 of the quality measures NQF just endorsed were authored by Ingenix. We're going to continue to play at all levels in the healthcare system with that one goal: make it work better for everybody involved and drive the cost out of the system. So with that, I think we're out of time, and I want to thank you for your attention, and I will be around until tomorrow morning, so please grab me individually and ask whatever questions that you may not have a chance to ask today.